Hi, I'm Dr. Mike Milligan. We're here at the Cleveland Clinic for the American Academy for Oral Systemic Health meeting. I'm with Dr. James Winde of Kennewick, Washington. James, thanks so much for being with us.
Nice to see you, Mike.
Okay, great. Well, James just spoke on sleep apnea, and he's a family physician who specializes in sleep now, limited your practice to sleep, and that's somewhat rare. It's usually a specialist.
Not many people in primary care medicine and family medicine especially are involved in sleep medicine.
So tell us a little bit about the uniqueness of that, and then some of the things you talked about in our meeting.
One of the things I like to do is interview patients who have sleep apnea. There are 84 diagnoses in sleep.
Okay.
However, sleep apnea is one of the chief diagnoses that we see. In a sleep lab, most of your nights are spent trying to find people with sleep apnea who need to be treated.
Okay.
That approach has changed over the last few years. Sleep apnea was traditionally treated by continuous positive airway pressure,
right?
CPAP. Not as popular as some people might think.
Right. People don't like them. Many people.
Many people. And if you look at it nationally, the effective rate, compliance rate, as we say, in sleep apnea is about 51%.
Right. About half.
Very poor.
Yeah.
So we like to offer things for patients that they may be able to do. Now, there are surgeries, there are orthodontics, but chief among the other alternatives are dental devices.
Right.
Easy to use, they fit in your shirt pocket, don't require power.
Right.
And that's a big point to make.
Okay.
Compliance is going to increase because the patient likes it better. It's easy to carry with you.
Right.
A number of people in the rural areas of the country do not want to be tied to electricity most of the time, and so they can carry this with them.
Right. Okay. Now, one of the things that you promote is a multidisciplinary approach, getting a number of people involved in diagnosing and treating this patient.
Mike, multidisciplinary clinics are not anything new from the standpoint of teaching facilities. We have done this all the time because it's an effective way of getting a large number of people into one area and teaching a large group of patients, usually residents or students.
You bet.
Taking that and moving it to the primary care sector is a little bit challenging, but if we can get this off the ground, I think what we'll do is bring people in from a wide variety of sources.
Right.
Ear, nose, and throat specialist, surgery, pulmonology, primary care physicians, dentists, orthodontists,
right.
oral surgeons. Get them all into one place and get them working on the patient in one session.
Right.
Usually probably be in once a month, half day of clinic, but where they will be able to speak with each other and the patient.
Right.
Involve the patient in the program itself. Involve him in the discussion. He can see the interplay of work between the primary care people and the specialists in each particular area and see our thinking in devising a plan for treating them long term.
Right. One of the things that caught my ear in visiting with you, you like to have a patient on CPAP for 100 days and then move them into an oral appliance at times.
Right. We look at the treatment protocols and we say CPAP is the gold standard right now.
Yep.
It works better for most people. However, we want to see how the airway heals in that first 100 days.
Right.
If they can, CPAP use is very, very important. Getting them to an adjunct treatment can become a challenge. If they've been on it and have proven that they can be on CPAP for about 3 months, the airway, the physiology, the biochemistry, and the behavioral activity of the patient will improve drastically. Then we can move on to other areas and try dental devices, surgery, and other adjunct means of treatment.
Right. And you talk about the physiology of sleep. Physiology of sleep. Tell us a little bit about that.
Sleep physiology governs a very large area because you have to go from the brain,
Right.
central neural control, through the airway all the way down to the respiratory pump itself,
You bet.
from the diaphragm and back. That control is very complex, and I like to teach a lot of different groups about the interplay of the different levels of physiology, whether it be the respiratory system itself, the distal control, as I do with dentists, on exactly how the upper airway musculature can be modified by a dental device,
Okay.
the use of CPAP, and the response from CPAP in the central nervous system, in the biochemistry, in the activity of the upper airway musculature.
Okay. What are the top few things that you would tell patients about sleep apnea and the need for treatment?
A lot of patients think that I'm treating sleep. Technically, I guess that would fit.
Right.
Sleep is an automatic process. We sleep, we're hardwired for sleep, is what I like to
Sure.
say. Sleep is going to happen no matter what.
Right.
But their sleep can be truncated, or problems can arise because of the physiology associated with it. The drive for respiration and other factors in the cardiovascular system are blunted by sleep itself.
Okay.
Those changes can cause people to have a higher incidence of stroke, heart attack, and worsening problems with high blood pressure.
Right.
Also, the patients are very sleepy. Now, that may be one of the cardinal effects, and certainly one of the great complaints they have. That won't in itself cause severe problems. I'm treating more of the cardiovascular consequences. But if you're tired, things may not work as well.
Sure. Absolutely.
Driving off the road if you're tired
Not a good
can
thing.
cause significant morbidity and mortality very instantly, rather than 20 to 30 years that it may take for sleep apnea to cause vascular
Or
damage.
even other accidents. But
Mhm.
what are the top few things that you would tell dentists about sleep apnea, the average dentist out there?
The average dentist that I try to work with, they're very familiar with sleep apnea. The specialty has been using dental appliances for quite some time, night guards. They see one of the cardinal symptoms of sleep apnea as bruxism.
Right.
Bruxing has been treated with a night guard, and very often they'll come in and say, this patient, or the patient will relate to me, I've been through 3 or 4 of those, I just bite through them.
Right through
because of the activation of the cranial nerves and the response of sleep apnea on the upper airway musculature.
Grind your teeth to wake yourself up enough to breathe.
To breathe.
Not even that you wake up enough to know that you woke up, but you just wake up enough to breathe. And
Right,
that's where that bruxing is.
we call those arousals.
Yeah.
Arousals are a shift from a lower level of neurocognitive function to a higher level, shifting from, say, stage 3 sleep upward to stage 1 sleep, but enough so that the respiratory control is brought back online enough to where airway resistance decreases and the drive for breathing has improved.
Great. What last few things would you like to say? Is there anything before we close?
Just that people don't realize the importance of the treatment of obstructive sleep apnea. This is 1 in 4 men, 1 in 9 women.
Right.
We need to get this treated as rapidly as possible. Although sleep apnea is a very common disease, CPAP remains the major treatment. It is not well tolerated. There are no gift certificates for CPAP. Nobody comes in and says, I would like CPAP for Christmas.
Right.
Those problems are necessitate us to look back at this and say, what other adjuncts to treatment can we develop?
Right.
I think that not to use one exclusively over the other, but a combination of CPAP therapy as that mainstay. But when the patient is going out of town or doing something elsewhere where he may not want to take his CPAP machine, take a dental device. Always have that option. Broader options, greater compliance. And I think that's one of the key points that needs to be made.
Dr. Winde, thank you so much for being with us.
Mike, thank you very much.
Okay.